Welcome back to the deep dive. Today we are doing something a little different. Usually when we talk about healthcare or, medicine, the mental image is pretty immediate. The hospital.
The beeping monitors,
Mm,
the sterile hallway.
exactly. The frantic energy of the ER or all the high-tech machinery in the ICU. But today we're leaving the
Why
building.
going upstream?
We are stepping out of that acute care setting and looking at where health actually happens, which is, out there in the community. For the nursing students listening, or really anyone interested in the machinery of how a society stays alive, this is your roadmap to community and public health nursing.
Yeah, and it's a really crucial distinction to make right at the top. Bedside nursing is so often about fixing what's already broken. It's reactive.
Right.
Community health is about keeping things from breaking in the first place.
Yeah.
It's about looking at the population as the patient rather than just the individual in the bed.
We have a huge stack of sources today, textbooks, government reports, a ton of research studies, and our mission is to synthesize all of that into hopefully a cohesive narrative. We're going to look at the human lifespan from birth to old age, and we're also going to look at specific vulnerable populations where the system is, well, really struggling.
And we'll be viewing all of this through three lenses: prevention, protection, and promotion. And maybe for the students taking notes, it's good to remember your levels of prevention: primary, secondary, and tertiary.
And I have to say, going through this material, there were some real aha moments for me. I mean, there are paradoxes here that just don't seem to make sense until you dig into the data.
Oh, absolutely.
Like why the U.S. spends a fortune on birth but has such terrible outcomes, or why a free apartment for someone struggling with addiction might actually be the most fiscally responsible move a city can make.
It's often really counterintuitive, but that's the beauty of public health data. It just strips away the assumptions and shows you what's actually happening on the ground.
So let's start at the very beginning, the starting line, maternal and infant health.
This is, well, it's traditionally considered the bellwether for a nation's overall health. If you want a quick snapshot of how well a country's healthcare system is functioning, you don't look at their heart transplant survival rates or their cosmetic surgery stats.
Right.
You look at two numbers: the maternal mortality rate, or MMR, and the infant mortality rate, the IMR.
And this brings us right to our first major paradox. The United States spends more on healthcare per capita than any other nation on Earth. We have the most advanced NICUs, the best surgical tech. So logically, you'd think we'd be the safest place on Earth to have a baby.
You would think so.
Yeah.
But the data tells a very, very different and, quite frankly, alarming story. Let's look at the maternal mortality rate. So this measures maternal deaths per 100,000 live births.
Okay.
In most developed nations, our economic peers, the UK, Canada, France, that rate usually hovers around 12.
Okay, so 12 deaths per 100,000. Where is the U.S. sitting?
Well, not only are we higher, but we are trending in completely the wrong direction. In 1987, the U.S. rate was 7.2.
Wow, that was actually really impressive.
It was great. But by 2016, that number had climbed to 16.9.
Wait, it more than doubled in the era of modern medicine? That seems impossible.
It's a staggering increase. Now, to be fair, we're still doing significantly better than developing countries, where the average is something like 239.
Right.
But for a country with our resources to be lagging so far behind the developed world and getting worse, that's a massive red flag.
So what's driving that? Is it just that mothers are older now, or that we have more chronic conditions going into pregnancy?
Those are definitely factors, certainly. Higher rates of hypertension, diabetes, obesity in the general population. That all translates to higher risk in pregnancy. But the aggregate number hides a much deeper, more painful disparity that nursing students need to be acutely aware of.
You're talking about the racial gap.
Yes.
Yeah.
The data is it's undeniable. Black women in the U.S. have a maternal mortality rate that is 3 to 4 times higher than white women.
3 to 4 times.
And this gap isn't closing. It has been widening ever since surveillance began in the mid-'80s.
So if I'm a CPHN or really any nurse doing an intake, this isn't just some statistic. This has to change how I assess the patient sitting in front of me.
It has to. It's a call to action. It's about assessment. It's about advocacy.
Yeah.
You have to recognize that not every patient walking into your clinic carries the same risk profile, even if their vitals look similar in that moment. It speaks to systemic issues, access to care, and maybe even how complaints of pain or distress are interpreted by medical staff.
Let's shift to the infants, the IMR. Are we seeing similar trends there?
We are, unfortunately. In 2016, the U.S. infant mortality rate was about 5.9 per 1,000 live births, which that translates to roughly 23,000 infants dying before their first birthday in a single year.
That is such a heavy number. But amidst all this gloom, the sources did highlight a massive success story, something that really proved public health education works. The Back to Sleep campaign.
This is a classic case study. We're talking about SIDS's sudden infant death syndrome.
Right.
It's the leading cause of death for infants between 1 month and 1 year of age. And for a long, long time, it was a total mystery. But research started to show a very strong correlation between stomach sleeping and SIDs.
So the campaign started in 1994.
Exactly. And the message was incredibly simple. Back to sleep. Just put the baby on their back, not the stomach, not the side, on the back.
And the results were?
Dramatic. Since 1994, SIDs rates have dropped by over 50%. We went from only about 35% of infants sleeping on their backs to about 70% today.
That's a huge win. But here's the question for the nursing student listening. Is your role just to hand the parents a brochure that says back to sleep and then just walk away?
Absolutely not. A brochure is passive. It's information. The nurse's role is modeling. It's active education.
Okay.
When that baby is in the hospital or when you're doing a home visit, the parents are watching you. If you lay the baby on its side just for a minute, or if you put a cute stuffed animal in the crib, you are silently telling the parents that those things are safe.
So you have to walk the walk every single time.
You have to demonstrate the entire safe sleep environment. Firm mattress. No soft bedding, no co-sleeping, no crib bumpers, and you have to explain why. Soft bedding looks cozy to a parent, but to an infant, it's a suffocation hazard.
Speaking of home visits, let's unpack something called the Nurse-Family Partnership, or NFP. The source material refers to this as a gold standard for community health intervention.
It really is. This is Dr. David Old's program, and it's fascinating because it completely flips the script on how we usually deliver care.
How so?
Usually, you go to the doctor, you get seen for 15 minutes, you leave. The NFP matches a registered nurse with a first-time mom early in her pregnancy, and that nurse visits the home consistently until the child turns 2 years old.
2 years. That's a serious relationship.
That is the whole point. The nurse stops being just a clinical authority figure and becomes a trusted ally, a confidant. The sources describe the nurse as almost a life coach. It's built on attachment theory and self-efficacy theory.
So they aren't just there checking blood pressure and weight.
Oh, they are doing that for sure. But they are also teaching parenting skills, helping the mother plan for economic self-sufficiency, navigating relationships, and making sure the child is hitting all their developmental milestones.
And the outcomes. Do they justify the cost of that intensive of a program?
Consistently, yes. We see improvements in maternal economic stability, which means fewer families on welfare long-term. We see better school readiness for the kids. And, crucially, we see significant reduction in child maltreatment.
Wow.
When you support the mother, you protect the child. It's that simple.
That trust factor you mentioned seems absolutely vital, especially when we start talking about higher risk of behaviors. The sources brought up this concept called double jeopardy regarding substance abuse.
This is a critical concept for nurses to understand. Imagine a pregnant woman who is using substances, opioids, alcohol, tobacco. That's the first jeopardy, the direct biological risk to the fetus.
Right. Makes sense.
But because she knows what she's doing is illegal, or at least heavily stigmatized, she's terrified, she fears legal ramifications, she fears Child Protective Services taking the baby away. So what does she do? She avoids prenatal care.
She hides.
She hides. That is the second jeopardy. Now you have a high-risk pregnancy with zero medical oversight. By the time she presents in labor, the opportunity for harm reduction is largely gone.
And we are seeing the results of this in neonatal abstinence syndrome, or NAS.
The statistics are just...
Yeah.
They're heartbreaking. Between 1999 and 2014, there was a 333% increase in NAS in the U.S.
Wow.
That equates to a baby being diagnosed with withdrawal symptoms every 25 minutes.
Every 25 minutes. That's hard to even comprehend.
And while opioids get the headlines, we absolutely cannot ignore alcohol. Fetal alcohol spectrum disorders, or FASDs.
Right. I think most people know fetal alcohol syndrome, the facial abnormalities, the severe delays.
Exactly. That's the most severe end of the spectrum. But the spectrum part is what nurses need to be detective-like about. There are subtler alcohol-related neurodevelopmental disorders. A child might look physically typical but struggle profoundly with math, have behavioral outbursts, or lack basic reasoning skills.
And without that diagnosis, they just get labeled as a bad kid or a problem child in school.
Precisely. And it's so important to note the environmental aspect here, too. The sources showed a really clear correlation between the density of tobacco and liquor stores in a neighborhood and the prevalence of smoking and drinking among pregnant women living there.
So if you live in a food desert, but there's a liquor store on every corner, the environment is actively working against your health.
It's actively shaping your choices. Exactly.
That segues perfectly to our next section. The child grows up, leaves the immediate home environment, and enters the school system. Section 2. School age and adolescent health.
And the school becomes the new health hub. There's a direct, undeniable link. Healthy children learn better. If you're hungry, or you're in pain, or you can't see the whiteboard, you are not learning algebra, period.
But the role of the school nurse has really shifted, hasn't it? I mean, it's not just lice checks and scrape knees anymore.
Not at all. It has shifted dramatically from infectious disease to chronic conditions. In the past, the big worries were measles, chickenpox, polio. Vaccines have, thankfully, largely managed those. Now, the school nurse is managing asthma, diabetes, and severe allergies.
Let's talk about asthma. It's a huge cause of absenteeism from school. The CDC has a strategy called Exhale. I love a good acronym. Let's break that down for the listener.
It's a great framework. E is for education, teaching the child and their parents self-management. I mean, does the kid actually know how to use their inhaler properly?
Right.
X is for extinguishing smoking and secondhand smoke in the child's environment. H is home visits, actually going to the house to look for triggers like mold, dust mites, or cockroaches.
That's that community nursing piece again, leaving the office, going to where the person lives.
Exactly. A is for achievement of medical management, making sure they're on the right medications. L is for linkages of care connecting the school, the home, and the pediatrician, so everyone's on the same page.
Yeah.
And E is for environmental policies at the school itself.
Like what?
Well, is the school bus idling right under the classroom window, pumping fumes in? Is there mold in the gym locker room? It's a whole system approach.
And we see a similar need for that kind of systemic thinking with type 2 diabetes. This used to be called adult onset diabetes.
We had to change the name because we started diagnosing it in children as young as 10 years old. It's driven almost entirely by the obesity epidemic and, frankly, sedentary lifestyles.
The stats on activity levels in the sources were pretty grim.
They're awful. Only about 15.4% of teens are active for 60 minutes a day. That's a very low bar, and we are completely missing it. The nursing intervention here is all about primary prevention. Nutrition education, advocating for healthier school lunches through things like the Healthy, Hunger-Free Kids Act, and just finding ways to get kids moving again.
Now, when we look at mortality, what is actually killing adolescents? It's not diabetes.
No. By far, it's unintentional injuries. Car crashes, drowning, poisoning. This is the leading cause of death for this age group.
Which is why things like graduated driver's licenses are actually public health tools.
Absolutely. Restricting night driving for new drivers, limiting the number of passengers in the car. These aren't just traffic laws. They are evidence-based, life-saving health interventions.
And the other major killer in this age group is suicide.
It's the third leading cause of death in adolescents. And this is where the school nurse needs to have their antenna up, always. They are often the first line of defense. They might be the first person to notice a student who is withdrawing or seems to be lacking what we call connectedness.
Connectedness.
It's a huge protective factor. If a student feels connected to a teacher, a coach, a nurse, a peer group, they are far less likely to engage in risk behaviors or self-harm. The nurse can be that connection, that one trusted adult.
We also need to touch on eating disorders, anorexia, bulimia, binge eating. There's a persistent stereotype that this is just a female issue.
It's a dangerous misconception. Males are affected too, though the presentation can be a little different. Boys might focus more on bulking up or obsessive leanness rather than just thinness. It's a very complex mix of culture, stress, and biology.
And finally, for this group, let's talk about reproductive health, specifically teen birth rates.
The good news is the trend is good. The rate is declining. It's down to 17.4 per 1,000 in 2018.
That sounds great.
It is, but again, context is everything. The U.S. rate is still significantly higher than other developed nations. Canada, for example, sits at 6.6.
So the CPHN role there is what? Counseling?
It's counseling, it's providing access to contraception, and above all else, it's confidentiality. If a teenager does not trust that the nurse will keep their confidence, they will not seek care. It's that simple. And that leads to unsafe practices.
So let's move up the ladder. Section 3, adult health, men and women.
This is the longest phase of the lifespan, obviously. And here we see what we call the gender gap in mortality really start to clarify.
The basic fact is women live longer.
On average, about 5 years longer than men. But living longer doesn't always mean living better. Women tend to have higher rates of chronic debilitating conditions, things like arthritis, depression, autoimmune issues. Men, on the other hand, have higher mortality rates at younger ages.
So why do men die younger? Is it purely biological?
Biology is definitely part of it, but behavior is huge. We often call men the reluctant patient. Socialization plays a big role here. Men are often taught to be tough, to ignore pain, to walk it off. They're less likely to have a primary care provider, less likely to get preventative screenings, and more likely to work in hazardous occupations.
But regardless of gender, the big killers remain the same for both.
Cardiovascular disease and cancer. They're number 1 and number 2.
Let's talk heart disease. You can't study public health without talking about the Framingham Heart Study.
It is the cornerstone. Started way back in 1948, it revolutionized medicine. Before Framingham, doctors largely just treated heart attacks after they happened.
Right.
Framingham gave us the concept of risk factors. It proved the link between high blood pressure, cholesterol, smoking, and heart disease. It shifted the entire paradigm from treatment to prevention.
But heart disease doesn't look the same in everyone. We have this image of the Hollywood heart attack, the guy clutching his chest and collapsing.
And that is the classic male presentation. But women often present very, very differently. They might report extreme fatigue, indigestion, back pain, or maybe sleep disturbances for weeks beforehand.
And if a nurse doesn't know that...
If a nurse is only looking for those Hollywood signs, they might send a woman home who is in active cardiac crisis.
Yeah.
It's a critical assessment distinction to make.
And for men, the risk just explodes as they get older.
It's a very steep curve. From about 3 per 1,000 at age 35 to 74 per 1,000 at age 85.
Let's pivot to cancer. Screening is obviously the main weapon here in public health.
For women, we have pretty well-established protocols. Mammograms for breast cancer, pap smears for cervical cancer. The Nurses' Health Study, another one of these massive longitudinal studies, provided the data for a lot of these guidelines.
But for men, and specifically prostate cancer, the guidance has become more, well, nuanced.
It has. Prostate cancer is the most common non-skin cancer in men, but it's often very, very slow growing. In the past, the philosophy was to screen everyone and treat everyone aggressively. Surgery, radiation, the works.
And those treatments have serious consequences.
Oh, severe consequences. Incontinence, impotence. We were treating 80-year-old men for a cancer that likely wouldn't have killed them for another 20 years. They were dying with the cancer, not of it.
So the cure was worse than the disease.
In terms of quality of life, often yes. So now, for older men with slow-growing tumors, we practice watchful waiting or active surveillance. We monitor it. If it stays dormant, we leave the man's quality of life intact. It takes a lot of health literacy and good communication from the nurse to explain to a patient why you aren't cutting out the cancer, but it's often the right call.
And the #1 cancer killer for both men and women.
Lung cancer. Which brings us right back to smoking prevention as the single most effective intervention we have.
The sources also touched on what's next, the future of adult health. Genomics.
Yeah, precision medicine. We are moving away from the one-size-fits-all approach. We know now that your genetic makeup can dictate how you respond to both disease and to drugs.
Like the BRCA mutation for breast cancer.
Exactly. If a woman carries the BRCA1 or BRCA2 mutation, her risk for breast and ovarian cancer is exponentially higher. Standard screening isn't enough for her. She might need prophylactic surgery.
Or even something like drug dosing. The sources mentioned warfarin.
Right, a common blood thinner. It's notoriously hard to dose correctly. We found that a gene variation, CYP2C9, affects how people metabolize it. If a nurse knows a patient has this variant, they can advocate for a very specific dosage, preventing clots or serious bleeding events.
So the nurse's role there is taking really detailed family histories.
Incredibly detailed. You're looking for patterns, like familial hypercholesterolemia, for example, that signal a genetic risk. You're looking for the blueprint of the family's health.
Okay, let's shift gears. We've covered the general lifespan. Now I want to focus on 2 specific populations that are often left behind, where the CPHN role is just absolutely vital. Section 4, disabilities.
This is a massive demographic. 61.4 million U.S. adults live with a disability. That is more than a quarter of the population.
And the sources emphasize using the ICF model to understand this.
The International Classification of Functioning. It's a huge shift in thinking. It views disability not just as a problem inside a person's body, but as an interaction between a health condition and the environment.
Can you give me an example of that?
Sure. Take a person with cerebral palsy who uses a wheelchair. That's the health condition. If that person approaches a building with a ramp and automatic doors, they can enter and function independently. In that moment, the disability is minimized.
Right.
But if that same building only has stairs and a heavy door, they are disabled. The environment disabled them.
That puts the responsibility on society to adapt, not just on the individual.
Exactly.
Yeah.
And the healthcare system is often a major offender here. There was a story in the source material, the weighing scale anecdote, that it really illustrated this perfectly.
Yeah, that one was tough to read.
It was about an obese woman who had avoided gynecological care for years, hadn't had a pap smear, no checkups. And the assumption from the clinic was just that she was non-compliant or didn't care about her health.
But that wasn't the reality at all.
Not at all. The reality was that the clinic's scale was located in a busy public hallway. She was terrified of the shame of being weighed in front of strangers, so she stayed away.
And that's such a fixable problem. Just move the scale.
Exactly. But because of that one environmental barrier, that lack of sensitivity, she missed years of primary and secondary prevention. That is what we call a missed opportunity.
So the nurse's role is assessment and advocacy, not just of the patient, but of the clinic itself.
You have to scan your own environment. Is this clinic accessible? Is the font on the forms large enough for someone with low vision? It's all about universal design.
Meaning?
Designing things so they work for everyone from the start. A curb cut on a sidewalk helps a wheelchair user, sure. But it also helps a parent with a stroller, a traveler with a suitcase, or a delivery person with a cart.
So when you design for accessibility, you usually end up making life better for everyone.
That's the principle. And we have legislation like the ADA, the Americans with Disabilities Act of 1990. It's civil rights legislation. But laws don't change culture. People do. Nurses do. We have to be the ones ensuring the interpreter is there for the deaf patient, or that the exam table lowers for the elderly patient.
Moving to our final population, Section 5, homelessness.
This is where public health hits the pavement, literally. And we need to be really clear about the definitions here.
It's not just the person you see sleeping in a park.
Right. There are the literally homeless, those in shelters, in cars, or on the street. But there is a huge, often invisible population of hidden homeless.
Okay.
People doubling up with friends or family, couch surfing night to night because they have nowhere else to go.
Which must make counting them an absolute nightmare.
It does. Point-in-time counts. Where volunteers go out on one night to count heads, they always underestimate the numbers. Period prevalence, which looks at homelessness over a full year, gives a much higher and more accurate picture of the problem.
And the health implications are just severe. The sources use this term trimorbidity.
That refers to the common and devastating coexistence of three things: mental illness, substance abuse, and a chronic physical illness.
It's a trifecta.
It is. And it's a vicious cycle.
Yeah.
If you have schizophrenia, it's hard to keep a job, so you lose your housing. Once you're on the street, you might use substances to cope with the cold and the fear. The substances then worsen the mental illness. It's a downward spiral.
Plus the sheer physical toll of living outside.
Frostbite, immersion foot from wearing wet socks for days, hypothermia, and incredibly high rates of infectious diseases like TB and HIV.
And trauma.
Trauma is central. Many people become homeless because of a trauma, and living on the street is itself profoundly traumatic. The courses talk about survival sex, trading sex for food or a place to sleep. The ACE scores, adverse childhood experiences in this population are off the charts.
So how do we intervene? The deep dive highlights a model called Housing First. This seems to be a total game changer.
It's a complete paradigm shift. The old model was treatment first. You had to get sober, get your meds stabilized, and basically prove you were ready before we would give you housing.
Which, I mean, that sounds logical on the surface.
It sounds logical, but it doesn't work. Try managing your diabetes or quitting heroin when you're sleeping under a bridge and you don't know where your next meal is coming from. It's impossible. Housing First says, give them the key. Give them a stable, safe place to live first. No preconditions.
And then what?
Then you wrap the services around them. You bring the social worker and the nurse to the apartment.
And the data supports this approach.
Overwhelmingly. Stability allows for health management. It dramatically reduces expensive ER visits and jail stays. It actually saves taxpayers money in the long run.
Now, there's a form of tertiary prevention mentioned that I imagine might be controversial to some listeners: wet shelters.
This is a challenging concept for many. A traditional shelter is dry. No alcohol allowed. If you show up drunk, you're out. A wet shelter allows individuals with severe alcohol use disorder to stay, and sometimes even to consume alcohol on site under supervision.
I can hear people saying, wait, aren't we just enabling them?
That is the common reaction. But you have to think about the alternative. If you kick them out, they're on the street. They might drink unsafe fluids like mouthwash to stave off withdrawal. They might pass out in the snow and freeze to death, or go into withdrawal seizures alone in an alley.
So it's harm reduction.
It is pure harm reduction. It's tertiary prevention. We are managing a chronic, severe condition to prevent death. We are meeting the patient where they are, not where we wish they were.
Meeting the patient where they are, that really seems to be the theme of this whole deep dive.
It is the absolute core of community nursing.
So we've covered so much ground, from the NICU to the streets. If I'm a nursing student trying to synthesize all this, what is my toolkit? What are the core skills?
Whether your client is a pregnant teen, a middle-aged man with heart disease, or homeless veteran, your tools are constant. Assessment, advocacy, and education.
And that education piece relies so heavily on health literacy.
Huge. You have to be a translator. You have to take complex medical jargon and translate it into language the patient understands and can act on. If they don't understand, they can't comply. It's that simple.
And finally, that upstream approach you mentioned at the beginning.
Always, always look upstream. We can treat the symptoms, the asthma attack, the skin infection, but the community and public health nurse always asks, why? Why is this person sick? Is it their housing? Is it poverty? Is it their education level? Those are the social determinants of health. If we don't address those, we're just putting Band-Aids on bullet holes.
This has been a deep dive with a lot of heavy lifting, but it's so important.
It's the foundation of a healthy society. It really is.
Before we go, we always like to leave our listeners with a provocative thought, something to chew on.
Here's my challenge, especially to the students listening. Examine your own biases. When you see a homeless person on the street, or a patient who you label as non-compliant, what is your first gut-level thought? Do you see a problem person, a moral failing, or do you see a complex interaction of environment, biology, and trauma?
And how will that change the way you nurse?
That's the question.
Thank you for joining us on the Deep Dive. Stay curious, and we'll see you next time.